as an introduction, as a brief introduction, this topic is mainly to do with surgery, surgical specialties, broad specialties and super specialties. It is not strictly, it can be extrapolated also to the medical stream of degrees, considering the fact that even medical and super specialty medical degrees, we have a lot of intervention, etc. We have, a lot of skill is also required. But having said that, let us primarily assume that this is meant mainly for the broad specialty and super specialty subsets. Now, as we all know, surgery is a skill. We have already discussed this before. It is like any other skill. So, when we speak about a particular skill, it axiomatically invites the word performance. There has to be a performance on part of the profession. When a surgeon obtains a degree in our nation, immediately the day after he or she passes the examination, a certificate is given stating that you have obtained a degree, specialty or super specialty degree. Along with this degree certificate, there comes an inbuilt license to start operating the very next day. In our nation, the moment a person obtains a surgical degree, the next day there is no power across the face of the earth that can stop him or her from operating within the boundaries of our nation. The question that medical education restructuring curriculum would like to raise is, how does the patient society, how does the surgical society in general know for sure what is the proof of ability on part of the surgeon that he or she can truly operate upon a patient? Let us take the government's policy with respect to the MBBS graduate. As I've already said, the government has introduced the post-MBBS licentiate examination. Why? Because after finishing MBBS, how do we know that this particular doctor is capable of treating patients once he or she is out there in the society? The question here that is being raised is, after the basic degree itself, when this sort of a licentiate examination has been made mandatory by the government at the MBBS level, why is it not that we in our nation do not have a licentiate examination after a person obtains a surgical degree, be it at a broad specialty or super specialty? In other words, where is the proof of, where is the test of ability of a surgeon? How do we know whether he or she can operate? Why is it that in our nation we don't have a licentiate examination post-surgical degree, specialty or super specialty? The law of the land. First question, what does the law of the land say? The law of the land says two things. One, the moment a person gets his or her degree certificate, he or she can operate 24/7 into 365. Nobody can stop him. 3 years of training is over. It doesn't matter what training, what coaching, teaching, exposure, experience, no. He or she has passed an examination. He or she can operate. The question that is being asked here by medical education restructuring curriculum is, what is the exam that the person takes? He takes a theory, he or she takes a theory examination, a written theory examination. There is a practical meaning, there is a viva, there is a verbal examination, it is an oral examination where he or she analyzes the particular problem of a particular patient that is provided. Nowhere in our nation is the student, the exam going student, asked to perform the surgery and demonstrate his or her skill as a part of the final exit examination. Performance of the surgery, any surgery, is not a part of the exit exam curriculum. It is a purely theory, written and verbal, oral based examination. So the question automatically that every viewer can understand is, how can a verbal, oral, theory, written examination be a yardstick, be a metric or serve as a benchmark to say that he or she can operate physically, surgical skill. How is it a testimony for on-table operative surgical skill? What does the law of the land say? I would like to read it out. In the case November 30th, 2018, Junjunwala versus Mrs. Dhanvantari Kumar, doctors are not liable for the outcome of the surgery. The only assurance that such a professional can give or can be understood is that to have given by implication that he or she is possessed of the requisite skill. That means the moment a person has obtained a degree, it is assumed, it is presumed that he or she has the skill. What is the basis of this assumption? What is the basis of this presumption? Here is a person who is going to cut open a patient. Surgery means, to put it, let me put it very crudely for all the medical fraternity will understand me. Obviously, they know what it is, but for the viewers in general, surgery is nothing but taking a knife and cutting open the patient, that particular organ system, and opening and going inside the depths of that particular organ system and exercising the surgical skill and performing the procedure which is supposed to alleviate or ameliorate the disease with which the patient has been afflicted and for which the patient has come to the surgeon for a surgical definitive finalized treatment. On the same lines as the licentiate examination for MBBS, should there not be why should there not be the introduction of a surgical accreditation examination for broad specialty and super specialty professionals, consultants, post obtainment of their degree? Immediately there will be a barrage of questions. The first question that will be asked by everybody, they say that this is ridiculous. This is absolutely ridiculous, because of the first objection will be, is there any nation which mandates a surgical accreditation examination before allowing a particular professional post obtainment of the degree? Is there any nation? Is this rule available? Is this rule present in any nation? Answer is no. No country across the entire earth ever asks or mandates a practical demonstration of surgical skills after obtainment of degree. Why? It seems contradictory. It seems as though I am myself contradicting my own statement. No, it is the truth. The question here is why? It is because their training program for 3 years, 4 years, 5 years or 7 years, whatever it may be, whether it is in the United States or in the United Kingdom or Australia or any European nation, whatever it is, their training program is so well structured, their training program is so well configured, their training program is so well implemented that the student comes out as a surgeon. The student does not come out as a student. He or she comes out with all the skill set that is necessary to confidently go and deliver the goods as far as surgical practice is concerned. The system of training in the West is so well organized that the surgeon who comes out, before they let the surgeon out into the society, they make sure that he or she has the necessary skill set. Only then do they send the person. This is the reason why they don't need an accreditation examination. Is this system present in our nation? We have already discussed this in the chapter on surgical training in India, the present status, lacunae and remedial measures. Therefore, such an accreditation system is required. Having said this, the first statement that I would like to make, medical education restructuring curriculum would like to make, is this will not be mandatory. It means, it appears a bit ridiculous. You say that an accreditation examination is required and then you say that it is not mandatory. Yeah, nothing can be forced upon a particular individual in our nation. Ours is a democratic nation. You cannot force something upon somebody. MERC doesn't believe, MERC is not attempting to, MERC is not trying to put a proposal that is going to be obligatory or mandatory. Same thing as is present now, and that is student obtains an MS degree or a MCH degree, surgical degree. He or she, the next day, they are free to practice. Yes, but then there is something known as moral obligation. Surgery, as I just mentioned, is a very unique field. Is it not? Does it not become the moral duty or responsibility on part of the surgeon to give the best of the surgical treatment to the patient? And in order to give the best of the surgical treatment, a surgeon must have the best of the training. And what is the proof of the training? The patient, definitely no patient across the nation or even across the world dares to ask a surgeon, doctor, how many cases have you operated? What is your success rate? What is your failure rate? Nobody dares to ask. Nobody will ask. This being the case, the patient, the point that is being made is, the patient comes with utter humility and utter 100% faith, ensuring that he or she has the appropriate required amount of skill. And what is the proof of that skill? Where is the proof? A surgeon cannot be his own examiner. A surgeon cannot say that I am great. A surgeon cannot say, no surgeon says so, that I have absolute skill. There has to be a proof. Surgical accreditation examination. Therefore, we will now go into some of the questions that definitely the viewers will still have. I am a professor with 33 years experience. According to this medical education restructuring curriculum, a particular person is proposing accreditation examination. Do you mean to say that after 33 years of service, I should go and stand before somebody and demonstrate my skill, and that somebody will say, yes, you are capable of operating. I am due to retire in 2 years. What kind of a rubbish is this? Who should take the examination? Who should not take the examination? Who is the examiner? Who will come and ratify? Who will come and see you operating and certify that yes, you have the necessary skill? Who is that person to operate? Who is he? Who is she? Who has accredited that accreditor? What is his qualification? What is his or her qualification? What is his or her level of competence? So why should some person, some third party unknown to me come and, who is that person? There are hundreds and thousands of surgeons all across the nation. Do you mean to say that all of them have to give this accreditation examination? It is physically impossible. Therefore, what kind of a proposal is this? These are the questions that viewers will ask. I hope I have completed the entire umbrella of questions. I hope I have completed the entire gamut of questions. I repeat what I just said. First thing, MERC would like to make it very clear. This is not mandatory. As I said, I am 54-year-old. I have worked as an associate professor of cardiothoracic surgery. I have a little bit of understanding enough, common sense enough to realize that a professor or a person who has got a huge amount of experience, he or she, MERC is not saying that you have to come and give your accreditation examination. Sorry. MERC is not so dim-witted as to say so. That is not the point that is being made. This examination or this surgical accreditation examination would mainly be for the stream of graduates who are coming from now onwards. If, as I always say, If the government, if the surgical society, if the medical society finds that this is a sane proposal, if they find merit and logic in this proposal, if the powers that rule our nation, if they find that this is fit to be implemented, then the next question that would be asked is, and this is the question that obviously the viewers are waiting for, who needs to give the examination, who need not give the examination? In order to answer this question, on your screens, I would like to present this particular placard, which shows that for convenience and understanding's sake, we divide our surgical society into three parts. Small hospitals, nursing homes, small surgical centers, which are purely privately owned, self-owned, etc. You see, surgeons here, they are on their own. They are a smaller setup. We cannot, MERC doesn't believe in forcing anybody. If they feel like giving an accreditation examination, there is absolutely nothing like it. What is this accreditation examination? It means that, I must have defined this accreditation examination properly to begin with. A brief definition. It is nothing. It is just that in his or her own hospital, institute, or center of surgery, a particular surgeon goes to the theatre with his own team, with his or her own team of anesthetists, with his or her own team of surgical assistants and colleagues and whatever it is, whoever it is, with his own nursing team of intensivists, with a patient admitted by the surgeon himself or herself with due consent, having been worked up thoroughly by the surgeon himself, on a particular day, a surgeon goes and operates as usual. The only difference is that a team of surgeons or a single individual who would be known as the accreditor, who is a deemed master in the field of surgery, in that particular honor, subset, specialty or super specialty, as the case may be, will come and watch the surgeon performing the surgery. The surgeon, as always, would be confident and he would do the regular procedure, nothing at all. The accrediting surgeon would only be watching. He would be watching the usual skills: cutting, stitching, suturing, knotting, dissection, tissue discipline, what we say. He or she will have a look at the pre-operative preparation and the workup, the intra-operative conduct of the operation, the maneuvers, the standard of surgery, and lastly, the post-operative exercise of shifting the patient, connecting to ventilator, or whatever it is, the intensive care, and that's it. It is not the case that accrediting surgeon or the invited guest surgeon is going to jump into the surgical field. No. Therefore, if a surgeon is confident of his or her skills, how does it matter whether an accreditor is standing or the greatest surgeon of the nation is standing? He or she will continue to operate and showcase his or her skills. When a cricket match is being played, there will be 100,000 people watching the batsman or the bowler, as the case may be. What happens? Nothing happens. The bowler continues to play his or her own game. The batsman continues to play his or her own game. Surgical accreditation is nothing but a surgeon performing his or her own cases in his or her own setup. An accreditor will come and ratify. That is all there is to it. What MERC would like to stress here is that this should not be viewed with aggression or a confrontational attitude. That means, why should I give my examination? Who is that? Who will come and accredit me? What obligation am I to tell a patient or showcase my talent so that a patient will know whether I am accredited or not? This confrontational attitude is not very acceptable in any profession. We divide hospitals into three sets. The smaller hospitals, corporate hospitals, small nursing homes, surgical centers, etc. If any surgeon practicing there, if he or she wishes to give an accreditation examination, there is absolutely nothing like it. It is most admirable. One. The second set of hospitals are the corporate hospitals. You see, corporate hospitals corporate hospitals are absolutely independent hospitals, and a corporate hospital, there can be two scenarios. Scenario number one, a corporate surgeon might say that yes, I'm open for an accreditation examination. Any accreditor can come and watch me operate. I'll perform the operation. They can give their results, and that's it. Or the management of a corporate hospital can say that our chief surgeon or the head of department or the lead surgeon, as they say, he or she is an accomplished surgeon. His word, her word regarding the skill set of the consultants will be the bottom line for us. Government institutes. These are the teaching institutes. These are the institutes. This is where surgeons are created. And here is where we need to have teachers or faculty who have a brilliant skill set. It is only when the faculty, it is only when the teachers of surgery in a particular institution, when they are up to the mark, can they impart the skills to the student. MERC, with due humility, would like to say that the faculty in teaching institutes should mandatorily have a surgical accreditation examination. They should prove their mettle, METTLE, their ability unequivocally. Immediately there will be 100 questions. I am a professor, I am head of department, I am additional professor. I don't need to prove to anybody. Again, MERC would like to adopt a very no confrontational approach. Even in a government institute, even in a teaching institute, if a faculty says, I am not going to take the accreditation examination, nothing can be done. Nothing should be done. The person will continue to hold the post. Everything will go on as it is. The person, let us say a lecturer or an assistant professor, for example, he or she says that I am not interested in an accreditation examination. Nothing will happen. Lecturer will continue to have the OPD, continue to admit cases, continue to have an independent operation theatre as permitted by the head of department. Same thing with the assistant professor, whatever it is. Things will go on as usual. The only thing that MERC feels that is, if a lecturer or an assistant professor or an associate professor or an additional professor aims for a promotion in the rank, then it is desirable that he or she has to give a surgical accreditation examination before being promoted. Barring promotion, surgical accreditation degree will not be mandatory even in a government or an institute. This is fair and square. Therefore, to all the viewers, there is a placard that is going to be displayed. The flow chart of all these three. I request the viewers to please have a look. Small hospitals, small nursing homes, part 1. Corporate hospitals, mega hospitals, part 2. Government institutes, part 3. A particular surgeon will admit a case or a set of cases, work up, post the case. Once the case list is ready, he or she will write to the apex body stating that so and so, I am so and so, I belong to this specialty or super specialty surgical stream. I wish to give my accreditation examination. I have admitted these are the particulars of the patient. Kindly arrange for the same. The apex body will forward a list of surgeons. They will give a panel of surgeons, 3 or 4 surgeons. The applicant will choose his will choose a surgeon of his or her own choice and communicate to the apex body. Apex body in turn will communicate to the accrediting surgeon. He or she will interact with the applicant and a suitable date will be fixed up based on mutual convenience. The surgeon as usual will perform the surgery. The accrediting surgeon will view all the parameters. He or she will satisfy himself or herself regarding the skill of the surgeon. That's all. And the accreditor, whoever it is, he will interact with the surgeon. If there are any deficiencies or lacunae, if there are any minor deficiencies or lacunae, he or she will point them out and file a report and forward it to the apex body. Only in the rarest of the cases, if there are gross lacunae, if there are gross mistakes, or if there is absolutely no tissue discipline on part of the surgeon, a surgeon may be forced to say that you need to have some more practice before being accredited doctor. Therefore, you need to polish a bit on these aspects. That is all will be the, that is all is the vision of accreditation examination on part of medical education, restructure and curriculum. There is nothing confrontational. There is nothing frictional. This being the case, a small technical detail that is displayed on your screen. What are the levels of accreditation? MERC would like to divide accreditation into 3 levels: L1, L2, L3. L1 refers to the basic surgeries, the small surgeries. For example, when we take general surgery, appendix, hernia, hydrocele, circumcision, skin grafting, small surgeries. I mean, I'm sorry to use the word small surgery or minor surgery. Every surgery is a big surgery. Even if it is a small toenail, ingrowing toenail, it is a major surgery for the patient as well. Having said that, L1. L2 are the medium range surgeries. Thyroidectomy, mastectomy, modified radical mastectomy with axillary clearance, gastrojejunectomy, cholecystectomy, enteroenteric anastomosis, below-knee amputation or above-knee amputation, parotidectomy, etc., etc. I am giving you small examples. Level 3 surgeries are major surgeries. That means a radical neck dissection, total gastrectomy with Roux-en-Y anastomosis, hepatectomy, Whipple's triple resection, colectomies, APR, abdominoperineal dissection. These, similarly when it comes to neurosurgery, skull-base surgery, CP angle tumor, that means cerebellopontine angle tumor resection, multiple level fixation of disc prolapses, discectomy with multiple level fixation. These I envision are some of the examples of level 3 surgeries. So, having this divided into L1, L2, L3, still there will be a question on part of the viewers from the surgical community, and that is, all said and done, every surgeon is a human being. Every surgeon has his or her own, I don't want to use the word ego, but self-pride, self-esteem, etc. A surgeon will say, take me for example, let us not go into any other examples. I am a cardiac surgeon with 10 years having worked as associate professor. I obtained my degree in 2003 and since then I have been working. I have so many years experience. Based on my experience, why should I not be given the accreditation degree directly? MERC believes that accreditation should be a slightly flexible procedure, and I hope the surgical community would appreciate that, would understand and appreciate that MERC is not proposing any rigid proposition for a particular surgeon. Let us come to a threadbare example. There is a surgeon, post degree 5 years. The surgeon says that I am going to submit my records patient verifiable records, as we call it technically. I have performed 200 appendicectomy, 200 cholecystectomy, 100 hernia, 100 hydrocele, 50 below knee amputation. These are the names, these are the IP number, these are the OP number, these are the days I have operated, and this is the outcome. I will make a beautiful presentation, crystal clear chart, logbook, and I will present it to the apex body. Will I be eligible for accreditation directly? Yes. It is not the case. MERC does not say, MERC does not believe in being dogmatic by saying that, no, unless you show that you can operate, you will not be given. No, absolutely not at all. So this proves that these are flexible proposals and not rigid dogmatic proposals. Similarly, with respect to L2 level of accreditation, there is a surgeon who has completed 15 years and is working as an associate professor or a senior consultant in a major corporate hospital. He or she has performed same thing. 100 gastrectomies, 100 Whipples, 50 or 60 major pancreatic surgeries, Fustos procedures, 20 splenectomies, 25 to 30 thyroidectomies, major thyroidectomies, subtotal thyroidectomies. No need of accreditation examination. The surgeon can be given directly based on the patient verifiable records. Before we go to level 3, before MERC proposes the final view on level 3, a different kind of a question will be asked by the viewers. A unique example. A particular surgeon has come out with an MS degree just yesterday, or an MCH degree, specialty or super specialty. That surgeon has been fortunate enough to work in a high volume center. Lots of exposure, lots of experience. He or she, in addition, has been fortunate to have a faculty, teachers, who have given this particular student n number of chances, surgical opportunities for 3 years. Excellent experience. Can he or she give the accreditation examination? MERC has no hesitation to say that the system proposed by MERC is so flexible that yesterday pass, today degree holder, he or she can take not level 1, level 2, level 3 examination directly. What more does the Surgical Society want? What objection can the Surgical Society have with respect to this system of accreditation examination that is being proposed by Medical Education Restructuring Curriculum? On your screens is the final summary for the viewers. All that is being examined and verified in this entire process of accreditation is whether the surgeon is safe, knowledgeable, and skilled, and can be trusted upon to operate upon a patient safely as per the current standards of surgical practice. Thank you.